First of all, thank you very much for your very kind invitation. I am very honored to be here. Please allow me the next few minutes to present several things about endohepatology and EUS. Because as we all know, endosonography has been developed for the biliopancreatic diseases, and now more and more there are talk about how the liver can be assessed by endoscopic ultrasound, because there are several limitations, and the main one is the fact that due to the proximity with the stomach, we cannot see all the liver. The right part of the liver cannot be assessed by EUS. So in this situation, we have to take into consideration and to go back to anatomy. So we can see that here is the transducer, and here is the segment 2, which can be very nicely seen. Segment 3 is here beyond the left hepatic vein. Here in this section also we can see this part of the left of the portal vein and ligamentus teres, and of course left hepatic artery. And of course we can see in another position the segment 1, the segment 4, and here is the inferior vein, caval vein, and with sometimes we can see, as you can see here, the segment 8. So another part of the liver that we can assess is the hilum of the liver, and all the three elements are very well seen, although it's quite difficult sometimes to puncture this part. And of course, gallbladder can be very, very well seen, and this is an advantage because we are closer than transabdominal ultrasound, and in this situation we can see even very, very tiny stones inside. So where is the place for EUS? This is an example of a patient with this hyperechoic small round lesion, and in fact it was a patient with cirrhosis, and it was significant. They were significant for fibrosis. Usually hyperechoic masses are considered as benign masses, like hemangioma and sometimes NET, which are, let's say, very close to benign diseases, but not always. Another situation is when we have malignant masses which usually are inhomogeneous with two components, central, which is sometimes hyperechoic, and a hypoechoic layer just around, and their delineation cannot be seen very well many times. This is an example of what we can see here. It was a huge mass in the left lobe, and it's very easy to see that everything is with a vascularity inside, or in this situation we can see that all the elements are distort over here. So again, another sign of malignancy. So why this is so important? Because this is, you can see, it's quite an old study, 2007, and they showed that in case of comparing all the possibilities of imaging, EUS had a very good sensitivity of 100%, but of course it's not enough. We have to perform FNA regardless of echogenic features. And another task is to see if metastases can be seen by this method. And why this is important? Because in case of hepatocarcinoma, we can see additional or new lesions in about 1 of 4 patients, which is huge, in fact, and it is very, very important. Or another situation, we can see more metastases. In esophageal cancer is 7% more. In case of GI or lung cancer is 2.4%, which can be important. This is a very interesting study which showed that when they tried to compare CT scan with EUS, for right lobe there was not a significant difference. But for left lobe, the significance was important here, 0.05. So it is considered that it can increase the visualization of this kind of lesions. And now it's very important because we cannot talk too much in gastroenterology without histology. And in case of diffuse liver diseases, we are in fact limited in US because the needles, they are very expensive, more expensive than in case of percutaneous biopsy. And in this situation, where is the place for USFNA in case of diffuse liver diseases? Only in situations when the patient performs an EUS or gastroscopy under sedation and he needs also a liver biopsy, or in cases where the anatomy is modified due to previous surgery. So in this situation, in these two situations, we can go for USFNA. And it's, of course, the left lobe is very easy to be accessed. It's not so uncomfortable for the patient. It's safe. And there are two measurements that we have to look for. The first of it is the complete portal triads number. The second of all is the visible core. And this is a very nice study which compared the total length of the core obtained by three methods: percutaneous, by EUS, or transjugular. And as you can see here, there was a significant difference between EUS and percutaneous biopsy in this situation. And for number of portal spaces, also there was a difference between EUS and percutaneous in favor of EUS, but no difference compared to transjugular approach. Which needle? It's an important task because if we use a 22 gauge needle, this is not enough. Usually it's a 90 gauge needle which can assure enough material. It's possible to be done for the right lobe also, and this is an example, but only with 8 cases from all the patients. And other needles, like TrueCut needles, they are not considered good enough, and they are not sure for the patient and for the scope also. I will go very fast on this slide. What I want to show you here is that this kind of needle, it is called shark core needle, seems to be very, very good for this pathology. So we think that we will have future for it. The same. So when to use USFNA for solid liver masses? First of all, when we cannot see properly by transabdominal ultrasound, when the patient has important quantity of ascites, or it's not, or there is a failure or impossibility to perform percutaneous biopsy. Of course, these are the main indications for biopsy in case of solid liver mass, but there are several limitations, and we have to cooperate very, very well with our pathologists in case of such situations, especially for well-differentiated hepatocellular carcinoma. Technically, it's easy for the left lobe. It's more difficult for the right lobe, but this is not impossible, unless this part of subdiaphragmatic regions, which is very, very difficult to be seen and to be accessed. And this is one of our cases that where we performed the biopsy, and this was the aspect. And these are data from the literature, and as you can see, the diagnosis was very good, 90% in case of cytology, and even immunohistochemistry was possible in 85% of the cases. What about portal hypertension? Because this is a very, very important aspect in hepatology, and we are all very used to with this measurement of hepatic venous pressure gradient, which is quite uncomfortable for the patient with radiation exposure, and it's in fact it's not a direct measurement of the portal pressure. So it was imagined very tiny needle, 25 G needles, which had attached this manometer, and it was possible, and it's not technically difficult to put a needle inside the portal vein and to measure the pressure, and inside the hepatic vein. Sometimes could be difficult if the caudate lobe is large. This study is a recent study. Of course, we wait for further evaluation, but it could be the future. Another situation is in case of varices, and this is a case we had. You can see how impressive is this aspect, and the Doppler is also seen. And we look, of course, for perforating veins especially, and paracollateral veins also. And this is a meta-analysis which is very, very nice. It was published several years ago, and it showed that if the perforating veins are not are still present on EUS evaluation after prophylaxis for bleeding, then the risk for rebleeding is high compared to patients which had no perforating veins. And how can we do? Sometimes we inject under EUS cyanoacrylate, and this is how it looks like. This is the puncture with the needle inside the varices over here, and we inject here alcohol, and every time we check by Doppler to see after that if everything is okay, and it was good for our patient that time. This is another technique with coils, because the glubran is very risky for thromboembolic events. And these coils, they allow to reduce this complication. We don't use it yet, but we want to do it in the future, because according to this study, the risk of rebleeding is low, only 16%, and the obliteration of a perforating vein was high, about 90% of the patients. And of course, we have to take into consideration costs, because as you can see, although the number of sessions decreases when we use coils, the costs are higher compared to use of cyanoacrylate alone. And of course, this is still experimental in pigs. It's what gastroenterosonographers, they try to do for several years, at least 5 years, to perform tips by performing by EUS, but we will see in the future. Other possibilities is to inject to ethanol in the hepatic cysts, and as you can see here, compared to transcutaneous approach, here the number of cysts which were completely resolved was 5 from 8, much higher compared to 0 from 10. So this could be done in, with safe, without any complications. Of course, the drainage of biloma can be done. It's easy for the left lobe, and it's easy to put a catheter pigtail here. We did not perform it yet, but we want to do it in the future. And several case reports were done also for the right lobe, but I consider this is very, very difficult. Other techniques were done for embolization of the portal vein, for chemotherapy injection or alcoholization of liver metastasis, but these are still experimental, so we look forward for other studies. So in summary, we can do liver assessment by EUS. It's good for small lesions. EOS can be done for diffuse diseases, but especially for focal lesions. And it's an opportunity, and we hope to develop it in the future, for portal vein pathology. Thank you very much for your attention.